that septum is not going to worry her. But if she has menstrual problems, if she has sexual function problems, and if she has fertility problems, that's when we have to think of correction of the anomaly. So to correct the anomaly, we will go to the classification of the American Society, the same thing which Ramaraju showed you, but I'll try and see if I can show you some more things. So first of all, you think of the absent uterus with the XY gonad. Here we can do nothing about the uterus, but we have to excise the gonad because that's a possibly pre-malignant lesion. So no doubt about it, no compromise, procedure has to be done. So let's go on with that. It's very clear for everybody. We go to the Aqua Uterus. This would be the commonest uterine anomaly. As Ramaraju told us, to treat or not to treat is very controversial. And we can show you what happens. You can go into the uterine cavity. We use a 2.9 diagnostic hysteroscope. And with the diagnostic hysteroscope, get into the cavity, that's the endocervix, internal os, and then go straight into the cavity. Once we are in the cavity, you can see the fundus, and all you can see at the fundus is the ostia on one side, and then you see a depression in the center and an ostia on the other side. Question is, cut it or not? Now, you can cut it easily, but that still is not indication as to whether you should cut it. A very good indicator which he showed you is to follow the uterine volume. If the volume is adequate, it doesn't make any sense for you to cut it. But most of these are patients who have had failed IVF attempts when we try to use all techniques possible. So we've used just a simple monopolar needle with which we have cut the fundus. You can do the same thing with the resectoscope. You can do the same thing with a bipolar needle. But the difference is when you're using the resectoscope, you have to dilate the cervix and then only introduce the resectoscope. And you can imagine in the small uterus with a small cervix, when we are dilating the cervix, very often we take a big chunk of the cervix off, it just tears off. So this is the Aqua Uterus. So from the Aqua Uterus, we will go to the Septate Uterus, where things are a little clearer. You can see here that there is a septum. Now, I'm sure half of you will be wondering, why do you call this septum and why do you call this arcuate, the previous one arcuate? Because this is just a little deeper than the previous one. Now, here again, the same technique. You go in with the needle, under vision, cut it. Procedure is simple, takes about maybe a minute. It's an outpatient procedure and patient goes home. So cutting these small septae is very easy. You can see the septae are avascular. There's hardly any bleeding. You get to close to the ostia. Remember, the end point here still is to get to a level where the fundus is still pointing towards you and not pointing outward. So at that point we stop. Here I've used monopolar. You can do the same thing with bipolar. The advantage with bipolar is that you do not have to use glycine. But then again, the amount of glycine we use here is very, very minimal. So this is cutting the septum. You can see it's bigger than the arcuate one where we just incise a little bit of the myometrium, whereas here we have gone right up, cut it, made a nice cavity. But there are dangers one has to be careful of. The first danger is do your homework. Make sure it is not a biconvex uterus. I'll go into that aspect. So let's just stop this. And one of the dangers we have is if we get a uterus like the septate uterus. You think this is a single septum. I'll show you what actually happened in one of our patients. We went in with the hysteroscope. Here you can see, as against the previous case, both the cavities are very wide apart. But still, the ultrasound done was very substandard, and we could see the two cavities. So that's one side cavity. And then there was a broad septum, and we went to the other side cavity. So whenever you see such a broad septum, be a little worried. So I started cutting the septum very smartly. That's midway through the procedure. I started getting worried because one, compared to the previous one, the uterus is not opening out clearly. So we went ahead further. At this stage, I decided to put the laparoscope in, and you can see the picture in the laparoscope. So this is the problem where you will have a double uterus and you think it's a full septum, and a little more if I had cut, I would have made a hole there. So that is the danger of cutting a septum without doing your homework properly. So let's go more into this aspect. So the incidence of infertility, 3.9 versus 1.1. So the question is, did the septum cause infertility? We don't have any randomized controlled study on metroplasty, and should it be done is still controversial. But there are some definite points which would favor it to be done. The first is, it could reduce the incidence of miscarriage and preterm labor. The next is, the endometrium on the septum is abnormal. There are several reports coming in literature where they biopsied the endometrium on the septum, found it to be low on glands, low on ciliated epithelium, and thereby very poor in function. So if you have a placenta fixed there, you're bound to have problems with that pregnancy. Many small studies have shown pregnancy rates are to be better once the septum is corrected. And one of those studies is as late as 2010 September. This was a sort of meta-analysis of 18 studies of around 1,500 women. They found that they had a pregnancy rate of around 60% with a live birth rate of 45%. This is very, very impressive. And they had a complication of just 1.7%. But one interesting aspect of this study was that they had a rehysteroscopic rate of 6%. That means when they went and did a HSG or an ultrasound again, they found still a lot of septum residual. We've really not had too much of rehysteroscopy, but the advice these authors were giving is that to prevent that, should a laparoscopy also be done so that you can guide and decide where to stop the septum, to stop the incision. Again, I leave it to you to think of it. The next aspect we have to go to is the problem of the complete septum. Here you see two cervices, and once you put the scope in, you will go into one cavity, ostia, and then again to the other cavity and ostia. It's very, very interesting because each one of these you sit wondering what to do. Now, we have two options to do here. One is to just cut the cervix. You can see I use an ordinary monopolar knife, cut the cervix, and that's the cervix after cutting. You will not be able to identify it from the normal cervix if I ask you after a little time. And then I take the resectoscope in and then just cut the septum right up to the fundus. So this is the method of dealing with a complete septum, provided it's a single uterus and a complete septum with double cervix. Don't do it for the double uterus. And here again, there is another option. Some workers suggest to leave the cervix alone, just go above the cervix, cut the septum, and then cut upwards and make the cavity single. It's easy to say, but it's not very easy.